Uh, I think we have finished the perfumery talk. Mahadevan, next talk. Okay, so good afternoon. I thank the organizers for the kind invite, and this talk, which I'm going to which I'm going to present for you, is being with the courtesy of the CIPLA. So, utilizing premix insulin to match type 2 diabetes were the concerns and the patient needs for the. This is going to be much more of a pragmatic talk. And the flow of my talk would be, for the next 10 to 12 minutes, would be I'll be talking on the disease burden and understanding the triad. And this talk is primarily based for the young physicians and the postgraduates who are here. I'm not going to dwell too much on what is already known for the senior physicians and my distinguished peers. So I'll be just going through a couple of case studies, and then I give what is required. Even though it's a sponsored talk, there is definitely robust evidence to say so, and then of course I shall conclude. If you are looking at the disease impact, okay, and you know that very recently, especially the last month, IDF has got the guideline, atlas, which says that India has at 2024 90 million population of diabetes. Okay, it's not 101. This is again based upon the ICMR data. The current data says that between the ages of 18 to 79, I think we have around 90 million of people, and the prevalence of diabetes is almost 10.5% and above in India. Unfortunately, almost 1/3 of the population, that is 36.3% of Indian diabetic, have an HbA1c. Only 36 point, that is less than 1/3, having their A1C less than 7%. That means that majority of patients, despite so much of CMEs that is going on, so much of accessibility for anti-diabetic agents, oral as well as insulin, I think we have a lot of work to be done. And 80% of Indian diabetic patients, despite taking 3 oral hypoglycemic agents, their A1C is still above 7. And if you are looking at all the data that is required, that is there for your, that is there if whether it's a diabetic care, achieve, present, improve, or ICMR in-depth data, which has the maximum study on epidemiology, the prevalence, you can see that A1C is somewhere hovering between 8.5 and 9. And that also translates that there is definitely a high fasting as well as postprandial blood sugar. I think I shall also talk about the Carl-Monier data, which says that we have to focus on all the 3. That is the A1C. To get your A1C to target, you need to focus both on the fasting as well as the postprandial. The question is, why is this therapeutic inertia? We know so much. We have been counseling on patients, but still there is probably we are not appropriately initiating and escalating the therapy. The reason I'm telling that if we are failing in that, probably that also results in patient outcome. If there is a delay, this is again a data that says that retrospective study, we say the delay in initiation for more than 6 months can lead to an inadequate glycemic control. And when you know that inadequate glycemic control, that leads to so much of on the cost on treating the complications of diabetes, not just on the medication, escalating the medication, also on the cost of the medication. So that's where this therapeutic inertia, I think my esteemed peers will know that Kamlesh Kunti and his team from Leicester have done a lot of seminal study. Even in UK, there is going to be a lot of, almost 2 years has been spent patients with an A1C more than 7 before you escalate the therapy. So understanding the triad, what is fasting, postprandial and A1C to do, just a simple take-home message that which I am going to give in the next slide would be that 1 millimole, that is around approximately 18 milligram of deciliter in the fasting, can increase your A1C by 0.25, and 18 milligram of postprandial blood sugar can also increase your A1C by 0.16. So it is just not that we have to focus on either, but both. Okay, pre-meal and post-meal. And whenever I say this pre-meal and post-meal, don't take as breakfast as the only important thing. It includes all the meal, breakfast, lunch, and dinner. So when you are talking about a pre-meal and post-meal, if we are not able to get the sugars in target, I think your A1C probably will never come to what is being designed for that particular patient. And now I am going to talk on the Calmonia data, which of course, postgraduates should have this in your mind. Of course, we cannot extrapolate directly to our Asian population because we are always on a high carb diet. This is for the Caucasians who take carb at least 1 or 2 meals a day, and mostly they are protein based. But in India, if you can look, whatever may be the A1C, there is a very high impact on the postprandial blood glucose. What the Calmonia data says that versus your A1C, the contribution for the A1C is mostly because of the fasting. And when you come towards the normal, as what all the organizations agencies decide, get your A1C to 7 or below without producing hypoglycemia, I think then you will have to focus on the postprandial. But if you are looking at the data, you can see that between 7.3 to 9.3, it is both fasting and the postprandial equally contributing. So most of our patients come in that range. When they come to our hospital for visit or revisits, you can see that A1C is somewhere between 7.3 and 9.3. Outliers are there, then you will have to focus on that. That's where we had this probably a kind of a false fixation of fixing the fasting first. That's where the science why we start basal insulin at first came into picture. Again, that was for the Caucasian population. But for Indians, especially South Asians, especially for Indians, when you are taking high carbohydrate diet, I think we have to fix both fasting and postprandial. And you know that without getting postprandial under control, the probability of getting into cardiovascular risk is much higher. So we need to have a solution for this. And for that, that just giving basal insulin probably may not be good. It is good, but for a certain period of time. Once the A1C starts coming towards your 7, I think basal insulin per se will not, and this is for all patients who require insulin. We need to tackle the postprandial sugars by giving a prandial insulin. Let us see what are the RSSDI recommendations and why we take RSSDI, because this is our Indian the guidelines. They are made for India, for the Indian population. When do you want to initiate insulin? Insulin should be considered those who fail to reach the glycemic target for that particular patient. You have to look at the comorbid condition, so it is highly individualized. Despite the 3 anti-oral hypoglycemic agents, he is taking at the maximum tolerable dose. Or you can give in a patient who has severe hyperglycemia, who is symptomatic, who comes to hospital, who visits ER. We can start insulin as a temporary for getting over the glucotoxicity, or in hospital when he comes with an acute infection. When he comes for a critical care management, I think insulin has to be given. So there are the 3 or 4 classic reasons why we initiate insulin. And of course, August audience know the different kinds of insulin that are available, both basal and prandial. And my focus today for this session is going to be only on the premix insulin. Because why premix insulin? Because for an ordinary physician and for a postgraduate while he is training in his first year, that is the simplest way that he can manage this patient and outpatient. Because it has the least the complexity, because you for titration. Not for all though, but for garden variety and majority of patients who visit outpatient, or when you are transitioning or when you are discharging a patient from hospital care to an outpatient care, probably the transition to premix insulin would be the most ideal, because most of the patients probably cannot afford doing a self-monitoring of blood glucose, the intensive monitoring that is happening when the patients were hospitalized, where the basal bolus therapy is the strategy. So to initiate insulin, we have various methods. Again, what we do, how we do, it's all good as long as we know what is the purpose. So you can either initiate with an once daily basal insulin, again that is for the fixing the fasting, or you can give 1 day premix for the co-formulation, or you can give 2 times premix insulin. So all depends upon, I said this is highly individualized therapy, so there is no general guidelines, there is no specific guidelines, these are all general guidelines. All depends upon the patient's age, clinical features, his life expectancy, risk for hypoglycemia, because you always know that there is always CKD lingering in a patient is if a senior citizen. And last but most important thing that we probably don't talk now is the patient's preference, because he may be an elderly person, he may have his relative who is there only in the morning. They go for work, they come back very late. So you have to look at the social context and the patient preference while choosing insulin. And choose premix insulin. Why? Because we have so many of the reasons. And one of the important reason is that please look at this particular, the first statement. If you are having a postprandial spike of more than 54 milligram, that tells you that this patient definitely requires a prandial correction. Basal insulin probably may not be the answer for a long-term basis. You can still see that patients come every visit 7.4, 7.6. He never will try to get the patients below 7.2 or even close to 7. If the fasting plasma glucose by A1C, the ratio is less than 20. This is also another reason that you need to give a prandial correction, for which you have an ordinary already a prefabricated solution of a premix insulin. And if a patient has limited literacy and he does not have the logistic support, I think this is easy to understand, and probably the titration becomes much simpler. And patient is on, definitely the last one is common. Every patient that you know, that includes us, we all on a high carbohydrate diet. So premix insulin probably is the answer. If you are looking at the RSDI, probably we all may differ, because now it's not lifestyle and then we start metformin. It's always, we have given way with the sequential therapy. Always you have to take 2 class of agents if the HbA1c is going to be 7 and above. So metformin plus something. And now you know that European Society way back in 2018-19 itself, they said that SGLT probably could be the first monotherapy to start with. So we have to have a very pragmatic approach on what you have to choose. Definitely no monotherapy, probably if the A1C is more than 7, look at the obesity part of it. So you have to use OHA, failing which I think that injectables have to be started. And when you talk about injectables, now you know that we also have GLP-1RA as well as insulin. So based upon the patient's comorbid conditions, whether they're having CKD or atherosclerotic cardiovascular disease, you can decide on the injectables. When it comes to insulin, I think that you have one of the choices that RSDA says that for an Indian population, easy way out is to give a premix insulin. And you know the titration of the insulin, I don't have the time for it. So I'm just going for a case study, and then I'm going to close the topic. This is just for a case study that you have a male patient 64 years and above, suffering from diabetes for almost 7 years. A1C is about 8.9%. His last visit 6 months ago, his weight is 73. That means his BMI is 25.8. I knew that 25.8 comes as a class of obesity in Asian context, Indian context. And you have an A1C of 8.7. Both fasting and postprandial are on higher side. You have a creatinine of 1.1. And postgraduates, please don't rely just on the creatinine, always look with EGFR. EGFR is 75, that is good enough, that is grade 2. And then you have dyslipidemia in this patient. See that cholesterol, your triglycerides are high and your HDL is low, and of course LDL is way beyond the normal. So in this patient who has dyslipidemia, whose A1C is high and who is also obese, and look at the family history. Patient, the father had coronary artery disease at mid-age of 56. Mother is type 2 diabetics. Both parents are at already in high risk. And here you have a patient who is probably taking a high carb diet. And look at the medications he is already having. Oh, he is on 3 drugs for sugar control: Sita, glimepiride, and metformin. Apart from the other drugs that is required for his BP as well as for statin. He also has a urinary tract infection, and he was reluctant for frequent injections. That was the reason why probably he had not been given insulin prior. So what do you prefer? Now you have come to you, and he knows that things are not all right for him. So whether to start with premix or basal. What do you like to know? Said everything. A show of hands from youngsters. What do you like in this patient? Premix or basal? Just show of hands, quick. I have only 1 minute. I'm not seeing in your show of hands. You don't have to talk. Just show of hands. Premix, how many you want to? Basal? Okay. So I think I have done justice to the sponsor and to the meeting as well. That is probably in this patient, I'm just giving you one. I have teased out a case scenario. Here in this patient is on high carb diet, and you look at the calculation, postprandial spike is 65 and above. So simple and convenient reason, and I think there are a lot of evidence. For lack of time, I will not go into this evidence, but again, this evidence probably may not be good because we are mixing and matching a basal and prandial and basal with basal. Definitely this will score over. So we have a lot of evidence to say, but ultimately the gist is that patient was started on premix humalog mixed 10 units before breakfast. Dose was titrated at weekly intervals, and after 4 weeks it was then escalated to twice. Always remember, starting is good, but make sure that appropriate escalation or de-escalation, very important. De-escalation is also very important. With SGLT2 and GLP1 going on, you need to de-escalate slowly and meticulously to avoid euglycemic ketoacidosis. Definitely there is no role for, I would say no role for sulfonylureas when you are giving premix insulin 2 times a day, or you can reduce the dose of sulfonylureas so the patient does not go for hypoglycemia. So my dear colleagues and friends, to conclude this, as I initially alluded to, 1/3 of the patients with diabetes have only could achieve in India of A1C of less than 7. Significant association between postprandial and fasting blood glucose and A1C reinforces the need for the clinicians to use a more holistic approach. It's just not the fixing the fasting first can happen for all patients. We need to escalate as per the guidelines. Treatment with premix insulin was found to be effective and safe to most of the patients. Okay, now I will not say all the patients, most of the patients, to achieve the A1C. Thank you for your patient listening.